parts of your endocrine gland, endocrine system?
Thyroid.
We have thyroid, pituitary, adrenals. Those are parts of your endocrine system. And when you say endocrine, it involves secretion of hormones, okay? Secretion of hormones. So, ang first na organ is thyroid gland, okay? So, we'll discuss on the pathology of the thyroid gland. First slide, it's your simple goiter, okay? Simple goiter. Okay, so the diagnosis is based on the gross appearance, okay? Gross appearance. Because we have multinodular goiter, we also have a simple nodular goiter. When you say simple goiter, it's just one nodule, okay? One nodule. And like that multinodular, characteristic gross appearance is presence of multiple nodules, okay? Multiple nodules. Okay, the appearance of, the gross appearance is the presence of your gelatinous colloid, okay? A nodular mass with gelatinous colloid, okay? Nodular mass with gelatinous colloid. So here, what you can see is just the thyroid follicles. These are thyroid follicles, enlarged thyroid follicles in varying sizes. Okay, varying sizes. Example, ito, large colloid follicle, and then malaki. There are small thyroid follicles, colloid follicles. Closer view, it's lined by a simple cuboidal type of epithelium. Simple cuboidal type of epithelium. Okay, next is your Hashimoto's thyroiditis. You can remember, give the type of hypersensitivity reaction for your Hashimoto's. Type 4. Okay, it was classified in type 4 sa manual. But actually, based on its pathogenesis, it's both type 4 and type 2. Okay, type 2. So, the pathogenesis is failure of T cell tolerance, and then there would be cytotoxic CD8, cytotoxic T cell mediated injury. We also have cytokine-mediated inflammation and antimicrosomal antibody, in the presence of your antibody-mediated inflammation. So, characteristic appearance of your Hashimoto's, okay, is the presence of your lymphocytic infiltrates with lymphoid follicles. These are lymphocytic infiltrates with lymphoid follicles. Numerous lymphocytes with lymphoid follicles. So, yan, a closer view, you can see it is markedly infiltrated by lymphocytes with atrophy of the thyroid or colloid follicles, atrophy of the thyroid follicles. Okay. Okay, next is your follicular adenoma. Okay, follicular adenoma, it's a neoplastic proliferation of your follicular cells. Since it's adenoma, therefore it's benign. Okay, it's a benign condition. So, okay, you can remember in your neoplasia, what's the difference between your adenoma from that of the carcinoma? It's the presence of your capsular invasion. Okay, in your adenoma, there's no tumor cells infiltrating the capsule. Okay? So yeah, this is the mass, this is the fibrous capsule, and it's devoid of tumor cells. So here, this is a closer view showing you uniform appearance of cells. Okay? Benign appearing follicular cells. So you can see here, these are follicular cells. Diba normally, ang thyroid gland is made up of follicular cells, then colloid. However, when there is neoplastic proliferation of these follicular cells, compressed na ang colloid, and it's predominantly follicular cells. In some cases, you can see small or atrophy colloid follicle. You can see atrophy colloid follicle. So next is your follicular carcinoma. Okay? So looking at this picture,
Invasion.
presence of capsular invasion. Okay, so the distinction between your carcinoma from that of adenoma is the presence of your capsular invasion. Okay, another criteria is the presence of your vascular invasion for your carcinoma. Okay. Cytologically, means that ang cells, ang morphology ng cells, resembles that of a adenoma. However, the main difference is ito. Okay, most of the thyroid cancers are derived from follicular cells. They are derived from the follicular cells, except for the medullary carcinoma. They are derived from the parafollicular cells or the C cells. Okay, so what is the route of spread for this type of cancer? It's hematogenous. Okay, hematogenous. Your papillary carcinoma is lymphatic. Okay, lymphatic. So here you can see slightly enlarged cells, but it has a uniform appearance. Slightly enlarged. Next is your papillary carcinoma. Papillary carcinoma. Okay, so the same as that of your follicular cell carcinoma, they are derived. The tumor cells for your papillary carcinoma is derived from that of the follicular cell. Okay, so here, from the diagnosis, it's papillary. Therefore, ang arrangement, you can see papillary configuration, or numerous papillae, okay, or finger-like projection. So this is a closer view. Ito, may fibrous core and there's a lining epithelium. There's fibrovascular core, tapos may lining epithelium. Now, okay, so the diagnostic criteria for your papillary carcinoma is not actually the presence of your papillae, but the nuclear features. Okay, the nuclear features. Okay, what is the characteristic nuclear feature of your papillary carcinoma? Okay, orphan Annie eye. Okay, what is orphan Annie eye?
Iba yun, orphan Annie. Yung nasa gitna ang nucleus niya.
Look at your eyes. Diba may pupil? Diba? May pupil. Pero si Orphan Annie, it's a cartoon character na walang pupil. So it's an empty eye. So, puro sclera lang lahat. Walang
Puti
pupil.
lang siya.
Okay, so that's Orphan Annie. So just like this, sa papillary carcinoma, ano siya, empty nuclei. Okay, empty nuclei. Look at this. Supposedly darkly stained ang nuclei, di ba? But because, yan, what happened is that ang chromatin is usually located in the periphery. Okay? So that's orphan Annie. Empty nuclei. Asa pa, kanino?
Parang may katarak.
So another nuclear feature of your papillary carcinoma is the presence of nuclear groove. Nuclear groove. Ito. Isa ito.
Taas.
Yan, nuclear groove. Here, nuclear groove. Ay, ito pala may closer view. So yan, ito yung
Orphan Annie.
orphan Annie. So next is your medullary carcinoma. Again, it's derived from parafollicular cells or your C cells. Okay, C cells. These C cells secrete what hormone? Calcitonin. Okay, they secrete calcitonin. Okay, so in your medullary carcinoma, the tumor cells are these, and it's surrounded by an amyloid. So these are amyloid protein. Okay, aside from your calcitonin, what are other hormones secreted by your C cells? I mean, there's tumor cells. We have polypeptide hormone, your VIP, and serotonin. That's why some patients with medullary carcinoma will present with diarrhea, diarrhea. So if you stain this, okay, if you stain this tumor cells with calcitonin, it will stain positive. Okay, so positive ito siya for calcitonin. So next is pheochromocytoma. Okay, so ang medullary carcinoma is derived from your C cells. Ito, pheochromocytoma, saan siya galing?
Sa chromatin cells.
Chromatin cells. Okay, so we have parts of your adrenals, right? We have the adrenal cortex and your adrenal medulla. Okay, saan siya banda?
Medulla.
In the adrenal medulla. Okay, so this is a very hemorrhagic mass. Okay, so they arise or derive from that of the chromatin cells. Okay, so pheochromocytoma. And they secrete what hormones?
Epinephrine.
Your epinephrine and your norepinephrine. So that patients with pheochromocytoma will present with hypertension, tachycardia. Okay, so those are the manifestation of your patients with pheochromocytoma. So characteristic feature of your pheochromocytoma is the presence of your cell balance arrangement. Cell balance. What is cell balance? It's nesting, okay, nesting of tumor cells. You can see a thin fibrous connective tissue that surrounds the tumor cells. That's nesting. Ito po. Ayun lang siya. Dili klaro. Okay, so cell balance. So next is your parathyroid hyperplasia. Okay, so when there is hyperplasia, it's associated with hyperparathyroidism. Okay, hyperparathyroidism. Pangit ang slide, no? Okay, so kung may parathyroid hyperplasia, okay, so there is an associated hyperparathyroidism. So going back to your physiology, what's the effect of your parathyroid hormone?
Increase calcium.
Increase calcium.
Regulation of calcium, di ba? Calcium
Parathyroid.
Okay, what is the net effect?
Increase calcium.
Hypercalcemia.
Hypercalcemia.
Okay, so the stimulus for the release of your parathyroid hormone is
hypocalcemia.
hypocalcemia or decrease in serum calcium. So when there is decrease in your serum calcium, there would be release of your parathyroid hormone, and this parathyroid hormone would be responsible for
Bone.
activation of your osteoclast for bone resorption. Okay, so there will be bone resorption. Aside from that, there will be increase in intestinal calcium absorption, and then there will be increase in the formation of your vitamin D. Okay, vitamin D. What is the other name of your vitamin D?
25 cholecalciferol.
Okay, so it's produced where?
Skin.
In the kidney. Okay, in the kidney, itong vitamin D. So yung vitamin D is also responsible for increase in the reabsorption of calcium in the kidney as well as the absorption of calcium in the intestine. So yan, physiology of your parathyroid hormone. Ito, so parathyroid hyperplasia. So kung may hyperplasia, what's the cause?
Increase workup.
Irritation.
Really? Hyperplasia.
Probably a decrease in calcium. Okay, so kung may decrease ng calcium, there will be proliferation of your
Parathyroid.
cheek cells in the parathyroid hormone. I mean parathyroid gland. So what you can see is a proliferation of uniform appearing clear cells or water clear cells. Yan. These are chief cells. Bantay-bantay mo sa sa endocrine kay parehas lang itsura.
Sobra.
Okay, so kasi ka parehas niya.
Seminoma, joke.
Seminoma. Okay, so Here, kung sa seminoma naman, di ba, large UTI. Here, smaller. Kasi, benign siya. Benign. How about, adenoma?
Even one.
Hindi.
Glance to glance.
Okay, so here, you can see a clear cytoplasm.
Pwede siya kuhan.
A clear cytoplasm for your
Neuroendocrine.
parathyroid hyperplasia. Clear cytoplasm with benign appearing uniform nuclei. So
Wow.
next is
Pituitary.
pituitary adenoma.
Asa na siya dating sa mga.
Okay, so what are the cells of your pituitary gland?
Lactotropes, somatotropes,
Thyrotropes,
gonadotropes,
somatotropes, gonadotropes.
gonadotropes.
Okay, so each cell would secrete hormones. Example, gonadotropes,
Gonads,
siya ng
FSH,
FSH and LH. Okay, so those are the hormones secreted by your gonadotropes. Thyrotropes,
Thyroid.
okay. So ano pa?
somatotropes,
Somatotropes,
Growth hormone.
growth hormone, and your prolactin.
Hindi.
Ano ba?
Sa kuhan yun.
Somatotropes din.
Okay,
Somatolactopes.
so ayun, kung may proliferation ng mga tropes ng mga cells,
Taas siya.
so yan, there would be pituitary adenoma. So, eto, how will you differentiate adenoma from that of parathyroid hyperplasia?
Malaki
Kasi
yung
almost
cell
the same.
yan. Mas
Kasi ito,
hyperchromatic.
kung tingnan mo, uniform.
Charm trap appearance.
Hindi
Wala, patawa lang ito mo guys.
Yung space. Ay.
The cytoplasm. Look at the cytoplasm. Okay, eto. Now, may closer view. Yan.
Mm.
Okay. Tingnan niyo yung cytoplasm. It's pinkish. Compared to parathyroid hyperplasia. Clear.
Clear.
So, ito, pink. So, pituitary adenoma. Okay, so what's the clinical manifestation of patients with lactotroph adenoma?
So, meron siya. Nipple discharge. Gynecomastia.
Prolactin. Gynecomastia.
Prolactinoma.
Ano nga yung gigantism and acromegaly?
Growth hormone.
Hormones in your somatotropes. Okay, somatotroph adenoma. So ano pa? How about Nelson syndrome? In your
ECTH.
corticotroph adenoma. Okay, corticotroph adenoma. So,
Wow.
let's go now to the diffuse adrenal gland hyperplasia. Again, what's the two parts of your adrenal gland?
Cortex and medulla.
Your cortex and medulla. Ito, ano yan? It's the adrenal cortex. And ito, the medulla. Okay? Ano yung mga cells dito?
Chromatin
cells. Okay, but here you can see 3 layers. Diba? May 3 layers. What are the 3 layers of your
Glomerulosa, fascicularis, reticularis.
Is your zona glomerulosa, which secretes what hormone?
Mineraloid.
It's your aldosterone.
Aldosterone.
Glomerulosa. Next is
Fasciculata.
fasciculata, secretes.
Hindi.
Cortisol.
Mineralo?
It's your cortisol. Okay, cortisol. At saka your
Androgen.
it's
Reticularis kay
secretes
Sex hormones.
sex hormones or your
Sex.
androgen. Okay, so itong adrenal gland hyperplasia is associated with hyperadrenalism. Okay, hyperadrenalism. Example, what are yung mga disease condition with hyperadrenalism? Cushing syndrome. Okay, which secretes or which has elevated cortisol level in the blood. Okay, next is hyperaldosteronism. So, increase in your aldosterone. Increase in the secretion of your aldosterone. Ano pa? adrenogenital syndrome kung may increase in your androgen hormones. Okay, so yan. So it is associated with your hyperadrenalism. Okay, yung cortisol, ano yung mga manifestation or clinical presentation of your Cushing syndrome?
Kasi buffalo hump.
Buffalo hump, central obesity, so yun yung mga presentation.
Straight.
Pag hyperaldosteronism, ano yung characteristic feature?
Characteristic.
Clinical feature.
Sa science.
Hypertension. Why?
Kasi
Aldosterone is
Okay, so yung aldosterone is responsible for the reabsorption of your sodium. And when there is increase in sodium reabsorption, water follows, there will be increase in the blood volume causing hypertension. So yung hyperaldosteronism. And aside from that, diba, there's if you reabsorb sodium, what happens? There will be secretion of your potassium. So then patients with hyperaldosteronism will present with hypokalemia. Okay, hypokalemia. Okay, what are the signs of your hypokalemia?
muscle weak.
Proximal or distal muscle weakness? It's proximal weakness for your hypokalemia. So yan. So yan kung hyperplastic, usually thicken yung cortex. There is thickening of the cortex. Okay. So it resembles just of the normal cells of the 3 layers. Okay. 3 zones. So walang atypia, it's just a normal appearing cells. Kaya lang may proliferation. So next is adrenocortical adenoma. Okay, adenoma. It's a benign proliferation of your adrenal cells. Okay, adrenal cells. So yan, adenoma, it's encapsulated. So is this hypofunctioning or hyperfunctioning?
Hyper.
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 Dapat mag-diffuse siya kung why.
It's hypofunctioning.
Wala ka na kasing puntahan.
Hormones.
Ah.
Okay.
Pero bakit siya malaki?
Unlike that of the carcinoma, it usually releases hormones. Okay, example, hormones released by your adrenocortical carcinoma is your androgen. Okay, androgen. So the patients with adrenocortical carcinoma would present with hirsutism. Okay, hirsutism. So yan, they are well encapsulated. So, okay, so itong adrenal cortical adenoma, they have the same cells as that of the cells of your zona reticularis. Okay, zona reticularis. It's vacuolated. So you can see lipid vacuoles in the cytoplasm. So next is adrenocortical carcinoma. So it will present with hirsutism, itong adrenal cortical carcinoma. And you can see here, yung capsule is infiltrated by the tumor cells. Okay, aside from that, there's presence of atypia. Okay, enlarged cells. Pleomorphic cells. So, okay, another thing is the presence of your hemorrhage and necrosis. Okay, necrosis. So, may necrosis, tapos may atypia for adrenocortical